Public comment, please.
Wesley Sheffield from Young Minds Advocacy, and I want to thank the OAC for their leadership in studying this issue. I want to echo some of the comments made that we're hearing repeatedly from families who are struggling to find basic care for their children who are in crisis. And we hear stories all the time of camping out in emergency rooms, waiting rooms, because there's just no place to put kids. And then add onto it that children often have to travel hundreds of miles from their families, limited support for transition. It's not good for kids. It's also not good for the system. These are really expensive treatments that can be avoided if we have an appropriate crisis response. I also want to point out that these are also services that children who are Medi-Cal eligible are entitled to under federal and state law. They're in this state Medicaid plan, they're required by the federal government, and these are programs that are done quite effectively by some of our sister states. We've worked with a number of other states who've implemented crisis programs for children and have seen enormous benefit for the children and a huge cost saving for the public system abroad.
Like who?
Washington State in particular just recently implemented their mobile crisis services. I wouldn't say that it doesn't have bugs in their system, but they have been able to work with families more proactively to avoid a child being pulled out of their home, having to enter into residential treatment. They also have been able to integrate it into their child and family team approach so that they can actively head off crises, work with families to develop skills to themselves deal with crisis, and then if necessary, bring in someone that's known to the child and the family to help deal with the crisis intervention, and in many cases avoid any kind of hospitalization or out-of-home placement.
Thank you for that. Appreciate it. Next witness.
Good afternoon, Madam Chair. Karen Savage, National Alliance on Mental Illness of California, and we want to thank all the staff, various departments who've been working on this. It's an important issue. Our members, who are individuals and family members living with serious mental illness, report instances similar to the one that Mr. Ewing mentioned. And I think it's really important that when we look at this issue that we take a sort of broad view of the services that are needed. So some of the ones mentioned in the proposal include, similar to SB 82, the crisis stabilization. And we think it's important that we also look at the services we're providing to children in schools. How are those fitting into the plans that we have so that children really have their holistic needs met in these situations, and also that we're looking at sort of our whole system of care. So we're looking at what we're providing in our community mental health system, but we're also looking at what hospitals are doing or are not doing right now for children, and what our health plans are doing or are not doing. And so I think as we move forward, we're very excited to see this being discussed, but we just want to encourage that broad view. And thank you for the opportunity to participate thus far at the OAC in this.
Thank you. Next witness.
Rusty Selix, California Council of Community Behavioral Health Agencies. We commend your staff and the OAC for bringing this issue to the attention. SB 82 theoretically would have also covered children's facilities, but it didn't tend to happen. So we think a new set aside of some one-time money. The need for children is much less quantitatively than for adults, but problematically much larger.
Right.
In other words, the children have much longer waiting times, much more difficult to find services.
Right.
The overall need is less, and that's why there's so much less of it.
Right.
So the unmet need on a percentage basis is greater and a total needs less. So you don't need as much money statewide, and you may need some regional approaches because the numbers in some of these crisis programs of children you'll need at any point in time is fairly small. But I think this is a great idea, and it would be an excellent use of some portion of the so-called one-time money, and we recognize the volatility of the fund as to how much to spend, but this would be a great idea and a great complement to the Oversight Commission's report and their triage system and other funding to establish this program. So we strongly support this recommendation.
Mr. Selix has spoken. It's a great idea. Thank you. It's hard being a kid. You know, just, whew, it's hard. Okay, with that, we'll move on to Suicide Hotlines, Issue 3 on page 38. Come around this side, whatever's easier.
you so much. Brenda Graylish, DHCS. So providing an overview of the suicide hotline issue. So it's our understanding that the legislature was approached by some of the call centers, the AAS accredited call centers American Association of Suicidology accredited call centers had approached the legislature seeking funding to supplement the funding loss from the Cal Mesa funding that they'd received for a few years. Through those conversations, we're required through the supplemental report to produce a report on the suicide hotlines through several criteria. Things like understanding the funding, the role of suicide hotlines, the role of the National Suicide Prevention Lifeline. And so we embarked on that project. We formed an advisory group, and through that advisory group, we structured the study to collect longitudinal data from these AAS accredited hotlines. We've collected staffing capacity data, call volume data, as well as funding source data. And right now, we're in the process. We've struggled a bit in terms of trying to get complete data from the AAS hotlines and trying to figure out how to standardize that data because it's not necessarily collected in a standardized way. So we've had a lot of back and forth with the hotlines, and they've been very helpful. At this point, we've got the data tables out to the hotlines so that they can validate the information, make sure we've taken, because they've provided us lots of different data sources, so we've had to take that information and categorize it, so we want to make sure that it's in line with their thoughts of how it should be categorized. While that's being examined or verified, kind of some of the global things that we've learned from this process is that, just by design of the system, all Californians who prefer to call a crisis line for advice and resources have 24/7 access to AAS accredited hotlines. Calls will continue to roll over until somebody answers them. So it can go maybe from that National Suicide Prevention Lifeline, and they'll transfer the call within one of the AAS accredited call centers. It'll continue to roll over, and it'll go to Nevada as our backup for the state. Yeah, and that's another question. There aren't any data to say, where in the process the calls get answered, or maybe even, where do people hang up and, not continue through with the call line. So that's something, and that's not unique to California. That's in general. But the way the system is designed, it'll continue to roll. So it doesn't go to a voicemail where somebody will leave a message. It'll continue to roll until a live person answers it. Excuse me. Most of the call centers use a translation service to provide advice and resources if needed. One of the other things that we learned is that access to the web-based and text features, so some of the hotlines actually are kind of technologically advanced, but it is very limited at this point in time. So another finding, one of the questions asked about a state-based or state-run suicide hotline. We asked the National Suicide Prevention Lifeline if they were aware of any such line in any other states, and they were not. So that was something else that we found. Also, just through the stakeholder process and having conversations, those who participated strongly advocated to keep the current suicide hotlines in operation as is, because there's a preference that for calls to be handled locally, and they thought that it was better if it were continued on in the same manner in which it's structured today. So again, one of the major limitations is the data. It's been, it has not been an easy process trying to look at data across the different suicide hotlines, as well as to, figure out how the data relate to one another. So in terms of like staffing capacity and call volume, that's another thing. There aren't any standards for, how many staff should you have per number of calls. And it could vary, and there's different volunteers on top of that. So and some of the volunteer data looks at people, not full-time equivalents. So then that's not equivalent to. So anyway, it's been challenging trying to figure out how best to interpret, to analyze and interpret this data. So at this point, we've got the data out to the hotlines, and we're hoping they'll have that back, their feedback back to us shortly or within the week. in which case then we'll finalize the report, make any necessary updates, and then finalize the report. So I think, and again, and I think our recommendations will come from that as well. So they're kind of on hold until we make sure we're understanding the data properly. So second question, does anything preclude counties from using MHSA funds to continue suicide hotlines? No, they may continue to use their MHSA funds for that. If they choose.
Any public comment on the suicide hotlines issue?
Rusty Felix, California Council for Community Behavioral Health Agency. So just to put this in context, about 8 years ago, again, through the leadership of Mr. Steinberg, a portion of county prevention early intervention funds were kept at the state level by agreement with the counties to start a series of statewide activities. One in 3 categories. One was suicide prevention, the second was stigma reduction, and the third was support for K through 12 and higher education services. As a result of that, the services in terms of these suicide hotlines was significantly augmented. That funding expired on June 30th, 2015. The 11 counties that are the host of those lines on a 1-year basis came up with the extra funding, utilizing their authority based on promises made by Cal Mesa, the Joint Powers Authority County, that they would find a way to come up with a way to collect the money statewide so that every county would be paying their fair share. For example, Los Angeles, half of their calls are coming from out of county. They're coming from elsewhere. They're supporting several other counties for the system and a way to create that. What we would ask for is find a way to ensure that the funding is there. The amount of funding being spent is about $4 million, 1% of prevention early intervention funds statewide. So if you could find a way, and it may take legislation, to earmark 1% of prevention early intervention funds, transfer it to the oversight commissioner, whomever, to distribute and figure out the lines, and also answer the questions that Ms. Graylish raised about what is the right level of care and all of that. It's a great thing that the Cal Mesa funding has continued for the social media campaign to drive people to the hotline. So more people are getting help as a result, but then the funding hasn't flowed with it. So we need to stabilize this and then grow this, and we think it's an appropriate thing to find a way to fund it. Hopefully the DHCS report will be back in time for May revise hearings, and we'll be able to find a funding source, whether it's something on a one-time basis we have to come from elsewhere, but it seems to me it's inevitable in the long run, whether the counties can do it collectively on their own, which I'm very doubtful about at this point, or the legislature could just earmark. It's about 1% of prevention early intervention funds. Find a way to do that. I think you're going to find similar things with regard to some of the other statewide efforts in suicide prevention and stigma reduction, but that's not on the agenda today, so I won't speak to that. Thank you.
Thank you, sir. Appreciate that. We now will move on to item 4560. It's being suggested that we could, since this is informational only and it's been discussed quite extensively, that we could skip issue 1 in terms of the overview.
Sure.
You comfortable with that?
Thank you very much, Madam Chair.
Let's move on to issue 2.
So in terms of the question number 2, I'm sorry, issue 2?
Issue 2. I thought crisis, children's crisis services, we talked about that. So I'm not keeping up with crossing off my work done. Yeah, so issue 2, Investment in Mental Health Wellness Act of 2013, the triage personnel grants. We're on page 40 of the agenda.
Yeah, thank you very much. So I think, as you know, the legislature provided the commission with about $32 million a year that we've issued an RFP for. These are $32 million a year for each year across 3 years. The commission has existing contracts with 24 counties to provide what we call our triage services. These are funds that are available to the counties to provide, among other strategies, peer navigators, folks who help keep people out of jails, out of hospitals, right? We describe it as a sort of a state-level innovation plan in the sense that there's not enough money for every county to get these funds, nor is there enough money for these funds to be available on an ongoing basis. The Commission has entered into contracts to the extent that the money is available. We're working with the counties. We hold regular quarterly meetings with our triage coordinators. The initial design of those meetings was really just to get the programs off the ground. How do you get the money? How do we get these programs going? We then began to work with the counties around some technical challenges, including opportunities for them to, say, bill Medi-Cal where appropriate. And so we've brought healthcare services into some of those meetings so that we can provide some technical assistance and support in terms of operationalizing those programs as they've been stood up. And now we're at the point where, I don't know how else to say it, we're really trying to work with counties so that they can collectively learn lessons among themselves, as well as share those lessons with each other. Myself and my chair were down in Los Angeles doing a ride-along with LA County PD and mental health outreach in Venice Beach, and one of the providers said, it would be really nice if we could actually share our stories with each other. And so we're talking about doing some open mic nights, so to speak, because there are lots of lessons being learned in terms of these programs that are specific to the folks who got the money, but we want to make sure that those lessons actually get disseminated much more broadly.
Right.
So
the counties that aren't reflected on page 41.
There you go. To the counties who may not have a parallel program, and as well as the counties who didn't get any of the funds, right? And along the way, we are learning our own lessons about how we can administer this program better over time. And so you'll see in the table that there are a number of counties that got funds. There are, I think it was 166 positions. One of the questions was about the positions that aren't filled. The bulk of those are in 3 counties, Los Angeles, San Francisco, and Orange. I think maybe Riverside has a few as well. And then it's 1, 2, or 3 kinds of positions that are vacant. There's lots of reasons for that. In LA's case, they really got started late in the process in terms of getting their contracts approved by the board and getting things up and running. And I think what we're seeing more than anything, in LA's case, it really is a lag. Similarly, the San Francisco program is a larger program, and so it's just taken some time to get those positions moving forward. We have found that this has been true for the program writ large. Even the smaller counties have struggled to find some folks in these positions, and one of the best examples is trying to find a clinician who's willing to work evenings, weekends, and holidays at the graveyard shift for pay that may not be as competitive on a grant program that has 3 years of funding, might not rise to the top of the list in terms of hiring opportunities, right? In Orange County's case, they're struggling because of the way in which they've tried to build sort of a public-private partnership down there, and getting all the parties to work together has been the big challenge. And so we're doing our best to give them space and time and support in terms of this program. So that's a little background on, so that's sort of the overview and a little background on the 166 positions that are vacant. That's also a little bit how we monitor under the contracts we have. The end of June, counties are required to give us evaluation reports. And those reports actually would extend from the beginning of the grant through March of this year. And so, although I think in the analysis it mentioned that the March deadline is that we've given them some months after March to gather their data and report back on their lessons learned. And our intention is to then work with them to really understand mostly about how they can learn among themselves, because they're actually smarter at what's happening in their communities than we are. And what we can do is facilitate those lessons and learn and listen in, and then monitor to make sure that issues around fidelity to their contracts and how the funds are used and all that, that there's a compliance piece. But really what we want to emphasize is the learning piece.
The third question, how many individuals have been served yet?
Yeah, about 13,000 so far. What we're finding is each quarter it's going up dramatically with, I think the last quarter was about 5,000 folks. And the counties are actually tracking the extent that those individuals are new folks being served versus the same folks coming back. And my recollection is that it's about 70 or 80% that is actually people who had not been seen by that program before. So there's a correlation between the ability of the counties to actually stand up these programs and have more people being served, and we think that's what's actually driving the increase in the numbers being served. So it's also, although it's a small number relative to the overall population of California, it's a significant number in terms of the impact on the system. And what we hope, consistent with the goal of the program, is that we're seeing that these kinds of interventions are really keeping people out of higher end programs that are more expensive, often less effective, and actually make it harder to deliver the kind of services that we need. But we're going to have to wait until we get those evaluation reports to be able to come back and talk with you about that.
Got it.
Did I miss anything?
Yeah, any comment from LEO, Finance, and public comment?
Good afternoon, Madam Chair. Adrienne Schulten with the County Behavioral Health Directors Association. I just wanted to, really want to support the triage grant personnel program. The counties that I work with report up to our association that these programs have been tremendously beneficial to more comprehensively serve clients. And I really also want to underscore what Mr. Ewing said about highlighting best practices and learning. So in addition to, working with the counties on that together, also to bring those practices here, to highlight them here, because I think we often hear about the examples that we've heard today about the folks that don't get served, but also there are some models we could talk about that what is working well in counties. So just wanted to put that forward as well. Thank you.
Thank you. Next witness, please.
Karen Savage, National Alliance on Mental Illness of California. I want to echo Adrienne's comments. We think this program has been tremendously successful from what our members report. These positions are very helpful to them when they're accessing services. And just a couple things to add. One is that we would really encourage the OAC to also partner with stakeholders when we're talking about lessons learned and best practices. We run some very similar programs to the triage grants that are not part of the triage grants on a volunteer basis in hospitals, having people provide these services. So I think there's a really good opportunity to partner there to talk about what are the best practices and how can we improve. And then we also think this is a really excellent opportunity. There are the peer workers in some of the triage programs, but we think it's a really excellent opportunity to continue to expand the use of peers and family members in our mental health delivery system. We see that as very successful in the programs that we run in terms of the outcomes. And so we think it's a good opportunity, particularly as counties are having some trouble filling positions, if they are, to talk about how do we do that, what is the efficacy of using peers, and continue that conversation. Thank you.
Thank you. We'll move on now to issue 3, the innovation plan reviews.
Thank you very much. And I would just, I would echo those comments that we look forward to working with NAMI and others, particularly on the peer issues and family member issues. And so I think that this really is about integrating the various aspects of the Commission's work so we can pull that together and get biggest value out of that. For issue 3, so under the law, the Commission reviews and approves innovation plans. And so counties must set aside 5% of their funds for innovation. And there's a process that we go through to review these plans. And we've learned a lot over the years in terms of how we can really help shape the opportunities in terms of innovation, but we're not yet at the point where we're able to bring together the various stakeholders to think about innovation opportunities as ways to bring about the transformational change that is key to the Mental Health Services Act, right? And so what we're finding is that individual counties are bringing forward really interesting, really creative proposals that range from adaptive applications to more innovative things. Now, in the grand scheme of things, the level of innovation is a little more in the conservative end of what you would expect, of what is sort of possible, and we're not seeing truly disruptive innovations, and I think that has a lot to do with the nature of the public sector and how funding is used and how public agencies think about these dollars. And what we're really trying to do is to reshape the conversation so that we are innovating collectively. It is more about that continuous learning opportunity for not just the counties, but providers, stakeholders, advocates, and the broad public. And so one of the things we've done is to reach out to the private sector and some business leaders and others to begin to talk about what are some of the ways that you use innovation as an opportunity to learn and to then shape decisions that are made and to really drive change and outcomes. And so what we have proposed for you is we are wanting to put together a innovation team that really takes advantage of the fact that under the regulatory authority that the legislature gave us around innovation will generate more information about what's happening in terms of innovation plans. And we want to be able to take that information and really work with our partners to think about what are the big key challenges facing California and how can we think about deploying the innovation dollars that are available more collectively. Right now, that doesn't mean that we would only ask counties to invest in collective opportunities because they have to go through their community process. But what we want to do is facilitate a state-level conversation or regional conversations about where there are shared challenges and to make sure we can learn across the different innovation opportunities. And so in order for us to be able to think strategically and engage the counties and our community stakeholders and others strategically, in order to be able to provide the technical assistance and support for that, because this is hard, as well as to do the evaluation and monitoring, and lastly, and most importantly, the dissemination of those lessons, that's the proposal that we've put in front of you. And we think it's a relatively small amount of money to really drive transformational change in an innovation budget that's about $100 million a year, which you can spend that money across 5 years. And so arguably there's about $500 million available in California. This is unheard of in the United States. It's unheard of in the health field, in the public sector, to have those kinds of resources and that kind of opportunity. And we want to make sure we're getting biggest bang for the buck.
I would completely agree. LAO, Finance, any public comment on the innovation plans? And indeed, what a unique opportunity to really think outside of the box as government, which we rarely have the luxury to do or the resources to do in a meaningful way. So that's exciting.
And we're doing a little bit of that now. We have a really small pilot to see if we can get transition-age youth to use social networking sites to actually talk to each other about the quality of services that are available and to actually guide each other. And so the best way to describe that is if you can land at the airport and use Yelp to find a good coffee shop, why can't a young person getting off a bus from the Midwest in LA get on there and see sort of the trail of breadcrumbs that the other 5,000 young people like him or her who landed in LA before that begin to see how other people are thinking and talking about what's available, what's good, what's tailored to who they are, right? And so we think that there are some low-cost, high-impact opportunities that could be really transformational in terms of access, quality, understanding of what's happening in our systems.
Fascinating. And that's a new innovative way, as we just talked about the challenges with the suicide hotline.
Absolutely.
How we use technology to provide quicker, the appropriate services quicker when needed. All right, did I ask for public comment? And I see none. Let's move on to issue 4, advocacy contracts. We're on page 44 of the agenda.
So historically, the Department of Mental Health entered into sole source contracts with a number of stakeholder groups in order to support their ability to participate in the policy and programmatic decision-making process. And that value is actually captured in the Mental Health Services Act. And the law says that a portion of these funds shall be made available to ensure that decisions about people who receive services are informed by people who have a history of mental health needs and their families. And so currently we have about $1.9 million per year in our budget to support advocacy contracts as outlined in the analysis. Last year, our budget was augmented by about $1 million to provide advocacy support for groups advocating on behalf of veterans, for persons working to reduce disparities, racial and ethnic disparities primarily, and then for transition-age youth. In that language, the legislature also directed the commission to move those contracts from sole source to a competitive RFP process. And so we're in the process now of working through that RFP. We're within weeks of issuing the RFP. And along the way, as the commission talked about this, it was made apparent, and I think this is one of the things that we talked about for a number of years, that there has not been advocacy support for the LGBTQ community. And so the commission asked us to explore opportunities. Are there available funds to support an advocacy contract for the LGBTQ community? And so that's the proposal you have in front of you. At the same time, the commission struggled with how to think about the amount of money that is available within each of these contracts. And so what they asked staff was, is there some rationale to the historic amounts that have been made available for these various groups? And our answer was no. That we can't say that there's a greater need for transition-age youth versus veterans or other communities. And so, the specific proposal in front of you that we've put forward would be to provide some funds so that the commission could enter into a competitive contract for advocates to actually engage around the mental health needs of the LGBTQ community. I think you'd asked a question in terms of the terms, 3 years is what we're envisioning. That's the way that the administrative rules around our budget allow us to function. We can spend money for the year you've given it to us, plus 2 additional years, unless you give us specific authority after that. So these contracts would be for 3 years for the most part. We currently have a number of contracts in place. Some of them are contracts that have been in place for a number of years. They're about to expire. The commission has asked us to make sure that there's no break in service, and so we're going to be close in terms of that. We also have a number of short-term contracts to get started. The $1 million that was put into our budget last year was subject to the availability of those funds. Those funds have not yet been made available, and so we're redirecting some of our existing dollars to do some short-term contracts, specifically for veterans advocacy and advocacy around racial and ethnic disparities. Let's see what else.
Before you move on, before we move off of this kind of general topic, you see under the comments section that the committee's in receipt of a augmentation concept or proposal that would bring all the contracts relatively the same level. Do you have any reaction to that?